Hello everyone, I'm Dr. Rohan Khandelwal, your marrow surgery faculty, and today we'll be talking about the INI-CET November 2023 surgery recall. Now, before I start the recall, I know that you've been battling preponements, postponements, preponements again, and there's a lot of chaos happening around you. But always understand that if the drive to do well is more inside you, then you'll not bother about this chaos. Anyways, we cannot change this chaos. It's not under our control. So this quote is very relevant. I survived because the fire inside me burned brighter than the fire around me. So I cannot control the fire around me, the chaos around me, but I can control my drive, my will to do well. And that is what I want of you. I think so this preponement of the NEET PG exam should work in your favor, and you should all give INI-CET a realistic attempt. Now, coming to the November 2023 surgery recall, it was a bit of an atypical surgery paper, right? INI-CET is known to ask questions from emergencies, from trauma, but there were hardly any questions from trauma. And as has been the trend in the last 2 or 3 years, GI and hepatobiliary system was the one which dominated the questions. Some of the questions were routine, which could have been answered easily. Some were previous year questions. Again, the percentage of previous year questions was also less, but some were extremely difficult and atypical questions, and we'll talk about all of them. Let's start with the endocrine surgery questions. Which one of the following is the most important prognostic factor for breast cancer? I think so. We've discussed, all of us have discussed this multiple times, that the most important prognostic factor, the single best answer here is axillary lymph node status. Right. So overall, axillary lymph node status is the most important prognostic factor. But if we talk about metastatic disease, right, if there is metastatic disease, then in those patients, the most important prognostic factor is the ER-PR status. Right, you need to understand one thing, that now the treatment of breast cancer is mainly governed by the biology, by the ER-PR HER2/neu which the patient is having, and that is what is determining most of the treatment, especially in metastatic cases, and ER-PR positive patients tend to do better. Now, there is another question which has been asked, and there's another table in Bailey which I want you to know, the good prognostic features, because last time in the INI-CET exam, it was asked as a multiple correct answer question. So, we know that lymph node negative is good prognosis. We know grade 1 is good prognosis, a lower grade or well differentiated is good prognosis. We know that ER-PR positive will be good prognosis, HER2/neu negative will be good prognosis. We know that BRCA negative will be good prognosis, right? LVI negative, LVI is lymphovascular invasion. If lymphovascular invasion is negative, it is going to be good prognosis. Similarly, PNI, perineural invasion negative, is good prognosis, and a low Ki-67. Ki-67 we know is a proliferation index marker, and there was another question based on the molecular subtypes which I'll talk about. So a low proliferation index is a good prognostic feature. So these are all good prognostic features, and the opposite of these would become bad prognostic features for breast cancer. This is a very important question, and all of you should be aware of it. Now, a 62-year-old lady comes with a hard, irregular, fixed, non-mobile lump in her breast. Her nipple is retracted, her skin is discolored, and her lymph nodes are enlarged. What does the tumor mean if it is luminal A? We know in the last 5 years, the molecular subtypes of breast cancer are being asked frequently in the exam, and we know that luminal A is the most common subtype. It is ER-PR positive, HER2/neu negative with a low proliferation index, right? So it is ER-PR positive, HER2/neu negative, and mild to moderate proliferation. It should be less than 14%. That will be the correct answer here. And we know that the IHC is immunohistochemistry. So whenever we diagnose a patient with breast cancer, we always do IHC markers. The ER-PR, that is estrogen and progesterone receptors, are graded in terms of the Allred score, which ranges from 0 to 8, and these are nuclear receptors. HER2/neu, this has been asked quite frequently in the exam. HER2/neu 0 and 1 plus are negative. 2 plus is considered as equivocal, and this has been asked multiple times in INI-CET and NEET PG. And for equivocal patients, we carry out FISH, that is fluorescent in situ hybridization. And if fish is negative, it is considered as negative. If fish is positive, it is considered as positive. Or if fish is amplified, it is positive, and this is a membranous receptor. These are the molecular subtypes for breast cancer. You should know that these are based on gene expression profiling. And I've just told you that luminal A is ERPR positive, HER2/neu negative, and a low Ki67. And luminal A is the most common subtype, and it has the best prognosis as well. These questions have also been asked in the exam. Luminal B, this is luminal B. Luminal B can either be like luminal A, that means ERPR positive, HER2/neu negative with a high Ki67, or it can be triple positive, as you can see, with any Ki67. HER2/neu enriched is ERPR negative and HER2/neu positive. Basal like is the classical triple negative, right? This is the classical triple negative which is there, and this occurs in young patients. It has worse prognosis. It has worse prognosis, and this all three are negative. Any Ki67 and cytokeratin 5 and 6 is positive here. Now this basal like cancer has the worst prognosis, but because the cells are dividing quickly, when you give chemotherapy, there is very good effect. So there is good response to chemotherapy. There is good response to chemo, but high chances of recurrence, right? High chances of recurrence, which is why this is called as the TNBC paradox, triple negative breast cancer paradox, that although it responds well to chemotherapy, it also has a high chance of recurrence. But one thing which I want to tell you here, which can be a potential question in the future INI-CET exams, is because it is showing good response to chemo, in triple negative breast cancers, we usually do NACT. NACT, you know, is neoadjuvant chemotherapy. That means chemo prior to surgery. So when we do this NACT, TNBC has highest PCR rate. What is this? This term has been added to the latest Bailey. PCR is pathological complete response rate, means the tumor literally shrinks or melts away when you give chemotherapy, right? So the tumor melts away, and when you do surgery after chemotherapy, there is no tumor there. That is called path-CR, and triple negative breast cancers have the highest path-CR rate. I want you to remember this. This is a potential question for future INI-CET exams. In the latest Bailey, they've also given a Claudin low type. The Claudin low type is also triple negative, but the differentiator is that in Claudin low, cytokeratin 5 and 6 is going to be negative. So this is regarding the molecular subtypes. You should remember this question regarding path-CR, what I've told you. Right. One more thing which I want you to know from breast cancer, in the last 2 years, questions from sentinel lymph node biopsy have not been asked. You should definitely revise this because it's a cyclical trend, and sentinel lymph node biopsy is very important for INI-CET. Also, the BIRAD scoring is also very important for the INI-CET exam from breast cancer. Now, there was a question regarding parathyroid adenoma localization. Now, in AIIMS, the endocrine surgery department is doing a lot of work on parathyroid surgeries and parathyroid illnesses. So, we know in the past questions have come from Miami protocol. That is, how do we ensure that the right gland has been removed? Questions have come from the radiological findings of hyperparathyroidism, and questions have been asked, where is the tissue implanted when we are doing surgery for hyperparathyroidism? We know it is the brachioradialis of the non-dominant hand. Here they've asked how to localize. Now we know that cyst is the one which is specific for parathyroid tissue, and this basically cyst targets the mitochondria which are present in these parathyroid glands. Now, if you read Bailey, they have written there are 3 protocols to do this cyst scan, right? And the next line written in Bailey is that all 3 protocols have similar sensitivity and specificity. But here they had asked which is the best. And when you read radiology books, in that SPECT system EB, because it is a 3D imaging, is said to be slightly better than technetium 99 system EB, which is said to be a 2D imaging. So as per this question, if you have to choose one when both are mentioned, it is better to go with SPECT system EB over technetium 99 system EB. So this is what is given in Bailey. So we will do a sesame bee and ultrasound for localization. If there is concordant imaging, that means sesame bee and ultrasound both are telling us the same thing. We do preoperative marking with ultrasound and we do minimally invasive parathyroidectomy. But if there is discordant imaging, means the sesame bee and ultrasound are showing us different things, then to settle the doubt we do a 4D CT and then we either do a 4-gland exploration or then we mark with ultrasound and do surgery. So this is how we proceed in patients with suspected parathyroid adenomas. Right, so those were the questions regarding endocrine surgery. Let's move on to the questions of GIT in hepatobiliary, which were quite a lot, especially the hepatobiliary, and there were in fact 2 questions from gallbladder cancer itself. So a patient comes to you with type 1 choledochal cyst. All of the following statements are correct except. So choledochal cyst, you know, is dilatation of the biliary tree, and this dilatation of the biliary tree gives rise to 2 things: stasis, which is going to give rise to jaundice, and 2, it increases the risk of cancer, that is cholangiocarcinoma. So this is a true statement. Cyst is opened and drainage is done. This is false, because just by drainage I will improve the jaundice, but I am not reducing the risk of cancer. So along with this, the abnormal mucosa should also be removed. The abnormal mucosa should also be removed, then only we reduce the risk of cholangiocarcinomas. Todani classification is used. This is also known as the modified Alonso-Lays classification. And this occurs due to anomalous pancreaticobiliary duct junction. This is called APBDJ, abnormal pancreaticobiliary duct junction, and this can increase the risk of GB cancer and cholangiocarcinoma both. Right, so it can increase the risk of GB cancer and cholangiocarcinoma both. This also we should be aware. So these are the various types of choledochal cysts, and the investigation of choice for choledochal cysts is an MRCP, and the patient is usually going to come with a lump, pain and jaundice. Type 1 is the most common type. This is diffuse dilatation of the CBD, and the treatment is that we resect this and we carry out a Roux-en-Y hepaticojejunostomy. So like I said, just drainage is not sufficient. You have to drain and remove the abnormal mucosa. Type 2 is just a diverticulum, which you can cut and repair the CBD. 3 has been asked in the exam. This is dilatation of the intraduodenal portion, which is also known as a choledococele, and this can be managed using ERCP with sphincterotomy. Type 4 is divided into 4A and 4B. 4A is when intra and extrahepatic radicals are involved, and whenever intrahepatic radicals are involved, we have no option but to carry out a transplant. So for 4A, we do a transplant, whereas 4B, which is only extrabiliary, extrahepatic, there we do portoenterostomy. We cut right up till the porta and then we do the anastomosis. Type 5 is known as Caroli's disease, which is only intrahepatic, and again, because it is intrahepatic, we need to do a transplant here. So like I said, there were 2 questions regarding gallbladder cancer. The first one was an elderly lady is diagnosed to have a gallbladder polyp. She has been told that gallbladder polyps have risk of gallbladder cancer. Which of the following is not a risk factor for gallbladder cancer? So we know that porcelain gallbladder is a risk factor, right? And the latest studies say that the risk is around 5 to 10%. This we know is calcification of the wall of the gallbladder, and if this is there, it should mandate an early cholecystectomy for the patient. Primary sclerosing cholangitis, which is seen with inflammatory bowel disease, this can again increase the risk of GB cancer and it can increase the risk of cholangiocarcinoma as well. Gallbladder stones more than 3 centimeters are also a risk factor, but a single polyp less than 1 centimeter is not a risk factor. So, polyps, according to the latest Bailey and GI surgery books, can either be cholesterol polyps, and these cholesterol polyps, they will not increase the risk of gallbladder cancer. But true adenomatous polyps will increase the risk of gallbladder cancer, provided they are more than 1 centimeter or 10 millimeters, or there are multiple sessile polyps which are there. Okay. Otherwise, if they are less than 1 centimeter, we just tell the patient to do regular monitoring. I myself have 3 in my gallbladder, but all of them are, 2 of them are 2 millimeters, 1 of them is 4 millimeters, and that has been the same case since the last 3.5 years since I've been monitoring them. So every 2 to 3 months I get an ultrasound done. Because they are not changing in size, I'm not getting a cholecystectomy done. But if any of the dangerous factors are there, a cholecystectomy should be carried out. So gallstones are a risk factor, Salmonella typhi carriers, porcelain gallbladder, more than 10 millimeter size of gallbladder polyps or multiple polyps, if they are sessile, we have discussed. Abnormal pancreatic or biliary duct junction, which I told you in the previous question. Heavy metal contamination of water is also linked with gallbladder cancer. Cholesterosis, which is strawberry gallbladder, is not a risk factor for gallbladder cancer. And mainly these patients come with a gallbladder mass, which is an early sign. This was asked in the NEET PG exam last year. And jaundice is a late sign. This is another question which has been asked. You need to know that this is a radiological diagnosis. We don't need to do a biopsy to confirm gallbladder cancer. This is what gallbladder polyps look like. This was asked around 3 years back in the INI-CET exam. This is a GB polyp, which you can see is slightly pedunculated. This is the gallbladder polyp, which we can see. So this was the second question on gallbladder cancer. A patient underwent a lap chole for cholelithiasis. Specimen revealed that she had gallbladder cancer infiltrating into the muscularis layer. What is the management for such a patient? Right, and we've discussed this in the classes that if somebody undergoes a lap chole and there's an incidental diagnosis, we know that it can either be a T1A GB cancer, which is above the muscle layer, right, which is above the muscle layer, T1B, which invades into the muscle layer. Now, if it is a T1A gallbladder cancer which comes out on cholecystectomy, no further surgery is required. You just keep the patient under observation, no further surgery is required. But if it is invading into the muscle layer, this is T1B, this patient requires an extended cholecystectomy, right? Now, extended cholecystectomy basically means that you have to go in again, you have to go in and you have to remove a 2 centimeter margin around the gallbladder fossa. You have to remove a 2 centimeter margin around the gallbladder fossa, plus you do lymph node removal that is along the hepatoduodenal ligament. Now, some people refer to this as radical cholecystectomy, right? So, radical cholecystectomy can also be done for T1B. Radical cholecystectomy basically means if you're doing an anatomical resection, and we have discussed in the past which 2 segments form the gallbladder fossa. It is segments 4B and 5. So, if I remove segments 4B and 5 plus the lymph nodes, then it will classify as a radical cholecystectomy. So, it is interchangeable. If you are doing a non-anatomical, it will be called extended. Otherwise, you can do a anatomical, which is segment 4B and 5. Now, if we go as per the guidelines for T1B, what has been recommended after the surgery is oral capecitabine. So, IV chemotherapy is not recommended after T1B, but for T2, T3 and T4, we will have to give IV chemo as well, right? And this IV chemo is usually a gemcitabine based chemo. Now, for T2, you can do surgery followed by chemo, followed by radiotherapy if required. For T3, T4, we usually give chemo first and then we do surgery and we do radiotherapy if required. Okay. So, that is the treatment protocol for gallbladder cancer which you should know about. Here the patient has tumor invading into the muscularis layer. So we will just do an extended cholecystectomy. If it was a T2 or a T3, then we would have done adjuvant chemo as well. But here just surgery is enough, and I have explained that to you. Okay, there were a couple of questions regarding hernias. One of them was a 63-year-old female comes to the OPD with abdominal pain and a tense, tender swelling below and lateral to the pubic tubercle. What is the most likely diagnosis in this condition? Right, so we've always discussed that any patient who comes with a hernia, you should always examine the patient in the standing position as well. And in the standing position, this helps us in differentiating an inguinal from a femoral hernia. Now, inguinal hernia, we know the reference point for both these would be the pubic tubercle, right? So, any swelling which is above and medial to the pubic tubercle, if this is above and medial to the pubic tubercle, this would be an inguinal hernia, or if it is below and lateral to the pubic tubercle, then it will classify as a femoral hernia, which is what will be the answer here. This would be a strangulated femoral hernia. Why strangulated? Because there is obstruction which is present, it is tense, tender, so probably the bowel is undergoing necrosis. You should be aware of the inguinal hernia anatomy. You already know about Hasselbalch's triangle. Hasselbalch's triangle, you know, is bounded by the outer border of rectus, the inguinal ligament, and you have the inferior epigastric vessels laterally. Any hernia coming out through this triangle will be a direct hernia. Any hernia coming out lateral to this is an indirect hernia. There was another question in the exam based on the anatomy of the inguinal canal. So, invariably INI-CET will ask questions from hernias, at least 1 to 2 questions are there. It has been some time since they asked about triangle of doom and triangle of pain, which you encounter during laparoscopic inguinal hernia surgery. You should know about the boundaries and the contents of triangle of doom and pain. They have been asked quite frequently. Also the nerves involved, because that has also been asked previously in the INI-CET exam. So I'm just giving you all these topics as well. When you're revising or you're watching this video, please make a note of these topics and do revise them as well before your INI-CET exam. Now, one-day term neonate presented with respiratory distress, tachypnea and a low oxygen saturation. And the key word here is scaphoid abdomen. Which of the following cannot be used for resuscitation? So, scaphoid abdomen classically means that the bowel is in the thoracic cavity, and that is why you will get a boat-shaped abdomen. So, we get a boat-shaped abdomen here, right? So, this bowel in the thoracic cavity would be seen in a diaphragmatic hernia, right? In a patient with a diaphragmatic hernia. So, these patients with a diaphragmatic hernia, we know that we cannot do bag and mask ventilation. Because if you do bag and mask ventilation, some amount of oxygen will go into the lungs, but some of it will go into the bowel as well. So, the bowel will also distend each time you do bag and mask ventilation. And when the bowel distends in the thoracic cavity, it will further compress the normal lung and it will further hamper breathing or ventilation for this patient. So, bag and mask ventilation can be counterproductive in these patients, and what we prefer is intubation and IPPV. Now, congenital diaphragmatic hernia, you know there are two main types. You have Bochdelic and Morgagni, and this has also been asked in the exam. Bochdelic is the most common. It is left posterolateral, and this is due to a defect in the development of the pleuroperitoneal canal or membrane. And what you have here is the stomach, spleen or the transverse colon. Morgagni is right anteromedial, and this is due to defective central tendon, and it has the transverse colon. This has also been asked. This is the classical X-ray of Bochdelic, which has also been previously asked in the INI-CET exam. And you can see the bowel lying in the thoracic cavity. And as I was explaining to you, that if the bowel becomes more distended, it is going to put pressure on the normal single functioning lung which is there and further hamper ventilation. You know that in congenital diaphragmatic hernia, the most common cause of death is pulmonary hypoplasia, right? That is the leading cause of death. The second most common cause of death has also been asked. It is pulmonary hypertension. And which ventilation is contraindicated? It is the bag and mask ventilation, which is contraindicated. And two times this was asked almost 6 years back in the INI-CET or the AIMS exam then, that a circular incision over the diaphragm should be made and then we should carry out the surgery. So this was a new question. They had asked you to identify the incision. Now, up till last year, they were focusing on appendicectomy incisions, and that is what they were asking frequently. And we've discussed that in the previous recall sessions as well. This one was a newer incision where they had given an incision which was slightly lower than the Lanz incision. Lanz would come somewhere here, which is used for appendicectomy. This is in the skin fold, or what we call as the love handles, and the incision is hidden there. This is a cosmetically superior incision for appendicectomy, the Lanz incision. But what they had asked was an incision which was slightly lower than that and close to the just above the inguinal ligament. This is a Gibson's incision, and this Gibson's incision is used for extraperitoneal identification of the ureter, for extraperitoneal dissection of ureter. And this is particularly useful in those patients where a renal transplant is being performed. We use this Gibson's incision to identify the ureter which is there. Okay, so this is a Gibson's incision. There are two more incisions which they had highlighted. You have the Battle incision, which is a pararectal incision, right? Battles is a pararectal, so it will be a transverse incision adjacent to the rectus abdominis. Robson's is a paramedian incision, right? Robson's will be a paramedian incision. So please identify the difference. Paramedian would be a horizontal incision, whereas the Battle incision is a pararectal, which is a transverse incision which is there, right? Gibson's I've already explained to you, Gibson's incision. There are other incisions as well. We know that we can have Cocker's incision for open cholecystectomy, and if you do a similar incision on the other side, that is a bilateral subcostal incision, this we know is a chevron or a rooftop incision which is used for Whipple surgery, and this has also been asked around 4 or 5 years back in the exam. You have the midline incision. For appendicectomy, you have the gridiron or the Rutherford Morris, which is fashioned over the McBurney's point. We know in gridiron we split the muscle, whereas in Rutherford Morris we cut the muscle. Lanz I've explained to you. Fannin steel is what we use for cesarean sections as well. So these are some of the incisions which you should be aware of. Last time they had asked about the positions of appendix. Prior to that, they had asked about the incisions for appendicectomy, and now they've asked about the Gibson's incision. This was also a difficult question asked for the first time. Which of the following classification of bile duct injury takes into account both vascular injury as well as the location of the injury? Now, you know that Bismuth and Strasberg classification has been asked in the past, and I've told you that Bismuth and Strasberg, for those preparing for the INI-CET exam, you should know about the Bismuth and Strasberg classification. So, Bismuth and Strasberg classification, they tell us about bile duct injury and they tell us about strictures as well. And previously, just once, Strasberg C has been asked, which is a leak from the aberrant right hepatic duct. Right, we know the Bismuth classification talks about strictures, and E1 to E5 of Strasberg also talks about strictures following surgery for the gallbladder, which can give rise to injury. So they both don't talk about vascular injury here. Okay. The Hanover classification is the one which talks about vascular injury also. Right, Hanover classification talks about vascular injury and the CBD injury. So this was the correct answer. It wasn't Bismuth or Strasberg. You also have the Stewart Way classification. So this is the Hanover classification, which you can see is talking about bile duct injury and the vascular injury. And I would not want you to remember the details. I doubt that it is going to be asked. Just remember that Hanover is for Both, right? You also have a Stewart-Way classification. The Stewart-Way classification takes into account, so this option was not McMahon, it was Stewart-Way classification. Stewart-Way classification also takes into account bile duct injury, which can occur during laparoscopy. So laparoscopic bile duct injury would be the Stewart-Way classification, which you need to know about. Mainly the details of Bismuth and Strasbourg primarily for INI-CET. Hanover is for both vascular and CBD injury. So when I was discussing the Bailey updates, I told you that now in Bailey there are 4 or 5 chapters on transplantation, and invariably INI-CET asks one question on transplantation, whether it is related to rejection. This time they had asked about indications for liver transplant in other malignancies. So they had asked, in which of the following malignancies a liver transplantation is not contraindicated. So we know for a fact that if breast cancer goes to the liver, there is no role of transplantation. It is already a metastatic advanced disease and we are doing palliative treatment. Same is the case for melanoma, same is the case for testicular cancer. Some people were saying that this was renal cell cancer instead of testicular cancer. It amounts to the same thing. In these three, if it has gone to the liver, it is mainly palliative treatment. We are not going aggressive. We cannot achieve cure. But one of the options here was colorectal cancer, right? Colorectal cancer was one of the options which was there. It wasn't, renal wasn't there at 2 places. So it was colorectal cancer which was the option. And this is the correct answer for liver transplantation can be done in patients of colorectal cancer. And this is what a table in Bailey says. This I've covered in the Bailey updates and transplant. Right. So we know that liver transplant for hepatic malignancy. We know about the Milan criteria, and there is a UKHCC and a UCSF criteria as well, which basically is telling us that we can do liver transplant in HCC, and Milan's has been asked. We know a single lesion less than 5 centimeters or 3 or fewer less than equal to 3 centimeters with no distant spread. We can do liver transplant in HCC. Okay. Now, they've also said colorectal cancer, neuroendocrine liver metastases are amongst the new indications for liver transplantation. So, for colorectal cancer also, we can carry out a neuroendocrine liver metastasis, we can carry out liver transplantation, provided, right, the mets can be resected and the patient can tolerate a transplant and has a donor, we can do transplant in these conditions. So, colorectal cancer, we can do a liver transplant as well. Right, so those were the questions regarding the hepatobiliary and GI surgery. Let's move on to general surgery and trauma. Right, so this was a question which was regarding clean, contaminated and dirty surgeries, which has been asked previously in the exam. It's just that the surgery was a new one, which was open cardiac massage. And open cardiac massage is basically a break and sterile technique. It would be done in the emergency, and you sometimes don't have time to adequately clean because the patient is almost about to die, so you have to act quickly, and this then becomes a contaminated surgery. When there is a break in the sterile technique, it will become a contaminated surgery. So clean wound, we already know, are clean incised wounds like thyroid, breast, uncomplicated inguinal hernia surgery. And here the risk of wound infection is 1 to 2%, whether you use antibiotic prophylaxis or you don't, right? We should definitely use antibiotic prophylaxis if we are putting in a mesh in hernia, if we are putting in an implant, or we are doing a grafting, definitely it should be used. Clean contaminated is when we enter the GI or the GU system, when there is no active inflammation. So this basically means I am doing surgery when the gallbladder is not inflamed or the appendix is not inflamed, right? So elective or interval cholecystectomy or appendicectomy is being done. Two more indications which fall here are cesarean and hysterectomy, which have also been asked, or we are doing bowel surgery if the bowel is not prepared. Here the risk of wound infection is 3% with prophylaxis and 6 to 9 without prophylaxis. This is what was asked in the INI-CET exam 3 years back. Contaminated surgery is when there is a break in sterile technique or we are entering the GI or the GU system when non-purulent inflammation is there, right? So, open cardiac massage also falls here. Open cardiac massage also falls here, and this would include emergency chole, emergency appendicectomy, or we are doing surgery for bowel obstruction. Here the risk is 6% with prophylaxis, 20 without. For dirty wounds, if there's pus, if there is contamination, then 7 to 8% with prophylaxis and 40% without prophylaxis. All your peritonitis cases also fall here. There was one question regarding burns, and there has always been a debate regarding how to calculate these values in burns patients. So, we know that the best method is the Lund and Browder chart, right? We know that this is the best method. But the Lund and Browder chart is a complicated method and it is a low percentage question, right? You have to remember so many values that you can get confused. So, I usually don't recommend that you remember the details of the Lund and Browder chart. I just want you to remember that it is the best. I want you to remember the Wallace rule of 9, right? We know the Wallace rule of 9 and we know the differences between adults and children. We know head and neck is 9, chest and abdomen is 18, back is 18, each upper limb is 9 in an adult, each lower limb is 18 in an adult, right? In a child, the head and neck forms a larger percentage of body surface area. So, head and neck combined is 18%. And where did we get this additional 9 from? We got the additional 9 from the lower limbs, which is why both the lower limbs now, instead of being 18, are 13 and a half. So, the question was, an industrial worker has burn injuries to the anterior region of the chest and abdomen. So, chest and abdomen is 18%. Okay, chest and abdomen is 18, as well as to his right upper limb. So, if the entire right upper limb is there, so right upper limb is 9, chest and abdomen is 18. Fine. He has circumferential burn to the right thigh. Now, if we look here, we know that in an adult, the upper limb, the lower limb is, each lower limb is 18, 9 front, 9 back. Okay. So, it is going to be 4.5 for the thigh, 4.5 for the rest of the leg, anterior, and 4.5 on the back. So, if there's circumferential just right thigh, that also amounts to 9%, right? So, right thigh would be 9%. So, if we add all this up, this comes to 36%, which is the correct answer, and this you need to remember for the exam. Okay. Questions regarding burns, regarding the types of burns have also been asked. Skin grafting have also been asked, and you should remember that. There was another question, most common cause of hypercalcemia in a hospitalized patient. So, we know that most common cause of hypercalcemia in a hospitalized patient is malignancy, and this is known as hypercalcemia of malignancy, which is a paraneoplastic syndrome. We know paraneoplastic syndromes are those syndromes which cannot be explained by the direct spread or by metastasis. They are usually explained by certain compounds released by the tumor, and this compound here is PTH related peptide, and this can be seen in squamous cell carcinoma of the lungs. We have seen it in metastatic breast cancer. I've also seen it in patients of metastatic prostate cancer as well. And these patients will come with confusion. Dehydration is how they come with. When you do the calcium values, they will be raised. And the management was asked 4 years back in the INI-CET exam. First, we have to do aggressive IV hydration. That is the first thing which is done here, aggressive IV hydration. Then we can use diuretics, but the drug of choice is bisphosphonates. But what I want you to remember is that these bisphosphonates are not to be added till adequate urine output is there and the kidney functions are normal. So we only add them once that has been done, otherwise first hydration has to be done. This is a repeat question asked multiple times in the exam. A middle-aged man comes to the OPD with a lesion shown below. What is the diagnosis? You know, over the face, a lesion with pearly white rolled out edges, and this is classical of a rodent ulcer, which is a basal cell carcinoma, and this has been asked many times. So this is also known as a rodent ulcer because it is locally invasive and because it is most commonly seen in the face above the line joining the angle of the mouth to ear lobule. This is also known as a teardrop cancer because this is the location through which the teardrop rolls down. These are locally invasive, they don't metastasize. That is why lymph nodes are also absent in these patients and you need to know about them. Okay. This was a basal cell carcinoma, which is a nodular basal cell carcinoma, and again a basal cell carcinoma which I had seen during my post graduation, and we carry out wide local excision with the flap reconstruction for basal cell carcinomas. So these were the questions which were there in surgery. There were no clinical questions from urology. From urology, questions were regarding the markers for urological tumors, which Dr. Ila is going to cover in her discussion. Right, so that brings us to the end of this discussion. Always remember, the bigger the challenge, the bigger the opportunity as well. And I again want to re-emphasize that this postponement, preponement thing must be disturbing. I totally understand, but it is also a great opportunity for all of you to prepare well for the INI-CET exam. And personally, I would try to finish my course 1 month before the INI-CET exam so that I can revise the course once before INI-CET, and then in the last 15 days again do a quick revision before the NEET PG exam so that you have a good chance of doing well in both. Also, let me tell you, target should be INI-CET. INI-CET is going to release the result quickly, even before the NEET PG exam. And some of you, if you do well, you might not need to appear for the NEET PG exam as well. So all the best, make full use of this opportunity. Thank you.